Okay, well, I'm going to get us started. I want to welcome everyone to this Friday presentation on DRISS Presents TEACH-RS. So if you're new to our seminar series, DRISS Presents TEACH-RS is a monthly lunchtime presentation where we learn about implementation science. And this year, we're also integrating into these seminars recruitment science. So the seminars take place every second Friday of the month from noon to 1. They are open to everyone, and it's part of our implementation science certificate that is run through the D&I Launchpad here at UW-Madison. So I am really excited to welcome Dr. Rachel Otis and her community partner team. And they're going to be presenting to us today on Madison's Community Alternative Response Emergency Services, which is called CARES, the implementation experience and research partnership. Joining Dr. Otis today is Shay Stedman. Shay is a recently retired from the City of Madison Fire Department, where he worked for 28 years. He retired as chief of the medical operations, where he was central to the implementation and operation of the city's mental health crisis response team. The CARES program involves multiple municipal and nonprofit agencies with the goal of providing appropriate crisis response to 911 calls in the City of Madison. Shay currently teaches part-time in the Protective Services Department at Madison College. Paco Banin is a paramedic with 15 years of experience encompassing the emergency room, 911, critical care, and flight environments. He was deployed in Afghanistan when COVID hit. Witnessing the struggles that isolation and uncertainty caused for patients prompted him to expand his understanding of mental health. Upon returning home and learning about the initiative for a mental health response team, he knew he had to join. Paco has been serving as a CARES medic since the launch of 2021. Dr. Rachel Otis is an assistant professor in the UW-Madison School of Nursing. Her research focuses on mental health systems and safe delivery of care for patients and providers. Rachel's prior research includes experiences of workplace violence in healthcare settings and the implementation of mobile crisis teams across the U.S. She is currently completing a project with the Madison CARES team, exploring the workforce experience. Rachel's a psychiatric nurse and draws on her decades of clinical experience in the behavioral mental health treatment setting. So I'm going to turn it over to Rachel and her community partner team to present their information on CARES. So Rachel, turning it to you.
Well, thank you so much for the introduction and the very kind welcome from everyone. It's great to have you with us. So I am just going to directly turn it over to Shay, who's going to get us started with the background of CARES, the story, the implementation, and then I will end with some of the research that we're doing together. So
thank you, everyone. Thanks, Barbara. Appreciate it. So I'm just going to take like 10 minutes maybe to kind of go through what CARES exactly is today, kind of that whole implementation phase and the research that we had to do to spin up a team like this in Madison. And then I'll talk a little bit about how we collected some data, and then I'll turn it over. And I think with the number of people on the call, I'm happy to take questions at any time. So please just either raise your hand, throw something in chat, or just pop on audio and interrupt me however you'd like to do it. As of today, the Madison CARES team is 3 separate teams that, and a single team is 1 community paramedic from the fire department and 1 crisis worker from Journey Mental Health. And so that single team will respond to a 911 call for nonviolent behavioral health emergencies here in Madison. And so the 3 teams that we have right now are working Monday through Friday, just during the day. So it's like 8 a.m. to 10 p.m. And then on the weekends, we have 1 team working a 10-hour shift. So it's not a 24/7 operation yet. And I'll get into a little bit of why that is. But the impetus for CARES If you can remember back to the summer of 2020, not only were we dealing with COVID, obviously, but a lot of social unrest. And one of the city alderpersons came to the fire chief at the time and said, "Hey, we need to do something different here in Madison." Madison was much like a lot of other communities, especially in the state of Wisconsin, where the primary mental health response was law enforcement. I had worked with Madison Police for the 28 years that I was a firefighter. They receive a lot of extra training around mental health. They have mental health officers. I believe that Madison Police do the best they can. But as you can all imagine, if you're having a behavioral health crisis, no matter how good a police officer is, when they walk through the door with a badge on their chest and a gun on their hip, it can be escalating for people. And we could spend probably another hour talking about the benefit of maybe not having law enforcement as the first person that walks through the door as a behavioral health crisis is unfolding. So fortunately, there were a lot of other programs around the country that were running similar models. So it just took some research and calling folks and a lot of emailing to kind of figure out what would be best practice here in Madison. The two programs that we really focused on initially were the San Francisco Street Crisis Response Team, which Rachel has quite a bit of experience with, and the STAR program in Denver. And the reason we focused on those two programs is because they were fire-based. Crisis response looks a lot different throughout the country. You can have co-responses with law enforcement. You can just send out crisis workers. But one of the better models, I feel, I'm a little bit biased, is the model that integrates a medical professional and a behavioral health professional. As you can imagine, there are needs both on the medical side and the behavioral health side with a lot of folks. And having that paramedic there that can provide medical assessments kind of in the background if needed, while the crisis worker is doing their job de-escalating and providing whatever intervention is necessary and providing those referral services. Those tools to have handy right away at the onset of a 911 call are incredibly important to the client, right? That being at the right person coming through the door at the right time in the right place, is really best practice right now around the country. So it took us about 9 months from the time that we kind of gave the Common Council the white paper on our proposal until we actually put a team on the street. And it needs to take that long, right? This is an important program to spin up. And the really big picture thing to think about is that the 911 system in Madison, like most places in the country, is about 50 years old. We can say that because that's when 911 was implemented. That's when paramedic services started. So we were asking our 911 center to do something different for the first time in 50 years. It's always just been you call 911, you get police, fire, or EMS. And now we're asking them to have a different resource, a fourth resource available to them, being the crisis response team or CARES team. So it wasn't just a matter of, the fire department hiring a couple of social workers and throwing them on the streets, right? It's quite a bit more complicated than that. And there's actually state statutes that kind of dictate what mobile crisis response needs to look like in the state of Wisconsin. And what they do is statutorily, they give authority to each county human services department. So the city of Madison Fire Department wasn't in a position, of course, to just do this all on their own. My first call was to Dane County Human Services. Luckily, they were very agreeable. They are the ones that needed to provide the crisis workers. And because they have a contract with Journey Mental Health is our partner in this. And so we pay Dane County Human Services the salary and benefits of the Journey crisis workers. And then we embed those crisis workers into the fire station so that they can respond with the paramedics for these calls. So we started our first team in September of 2021, and it was just one team that was working 8 hours a day, 5 days a week. We started small. It was because we had a small budget. Our initial ask of the city council was about $1.6 million for us to put a 24/7 team on the streets. And they came back and said, well, we'll give you 50,000 and we'll start a pilot program. And it's good to start small and be thoughtful and make sure that you're really providing best practices in the work that you're doing. And it involved a lot of community members, like Rachel was saying. It's not just Journey and Madison Fire and Dane County Human Services. It's the Dane County 911 Center. It's the Madison Police Department. It's our other local police agencies, right? We've got Capitol PD and UWPD and all the little police departments around us that need to be aware of care services as well. So there's a lot that goes into it, and it was brand new. But like I said, the fact that we had other really successful programs to lean on. And there's a lot of cohorts around the country that get together on monthly calls to talk about, hey, what kind of call types are you going on? What are you using for documentation? And so we're all doing our best to share information, which I think is incredibly important too. The struggles that we had, I will certainly say, were around hiring. We didn't just take our 911 paramedics that are riding around on ambulances and fire trucks and throw them into the crisis response arena. We very purposely hired civilian paramedics that had experience and that we felt were going to be able to take a step back and listen to people, right? Paramedics usually are very on task, help the person right now, get them to the hospital, drop them off, and go on the next call. It's a paradigm shift for us to sit back and listen to somebody and help somebody through a behavioral health crisis. It's much different than what we were tasked with before. Previously, we would have just picked a person up that was suicidal and taken them to the emergency room and left them there. And hopefully there was a good enough social worker at the hospital to help, but that isn't always the best process. Taking somebody to an ER when they're having a behavioral health emergency isn't always the best pathway for them. So I believe that we have shown success, but this is going to be what we're going to get into a little bit. It's easy to collect all the quantitative data, right? We've got a really good data dashboard. We know the number of calls we go on. We know the demographics of the patients we see. We know what their chief complaints are. We know where we transport them to. We know all of those kind of factual things that come from the 911 center, right? How long does it take to go on each call? All of that stuff. But we really struggled around qualitative stuff, right? Patient satisfaction. How do we really know that our program is successful? And we get asked that question a lot. And at one point, we actually tried to get some patient feedback. We created little postcards that we would give every patient, a self-addressed postcard with some questions on it. We handed out hundreds of them and got maybe about 20 of them back. And so it didn't seem to be the best way to survey folks. So if anybody on this call has any advice about how to do a good qualitative survey and figure out how you can figure patient satisfaction, I'd be happy to hear it. But so there were struggles, but fortunately, the thing that we didn't struggle with was support. We're funded by the general fund of the city of Madison. It wasn't grant funded. Journey Mental Health is able to bill insurance for their calls, so they're able to generate a little bit of revenue that way. But otherwise, it's a free service for folks as far as the Madison Fire Department is concerned. We feel like the program is certainly only sustainable with help from our Common Council and the mayor's office and from the taxpayers because it's a valuable service. I've been talking quick because I had a lot of coffee. I want to make sure I'm pausing for a question or if there's anything else. Rachel, do you think there's anything else you'd like me to elaborate on right now?
I think that's a pretty good overview of sort of where CARES came from and how it got started. So yeah, anybody have any questions about the sort of nuts and bolts of it and the origin story? This is sort of the main expert here for that part. So.
And obviously I'm sticking around. I can answer questions later as well.
Okay, ready. And maybe now, thanks for providing that foundation. And maybe now we'll have Paco step in and talk a little bit about, from the implementation side, from his perspective, what it has looked like. So Paco.
Thank you, Rachel, and thank you, Chief Stedman. And again, feel free to ask any questions at any point in time. What I wanted to talk about is a little bit more about the nuts and bolts of the program. Obviously we have this huge, large organizational, institutional framework that had to be put in place before we could even be a thought and in the grand scheme of emergency services. So myself and a dear colleague, Mark Norton, were brought in a few months earlier before the program went live. And some of our tasks were figuring out things from like what extra training we felt as medics we needed to have. UW Green Bay has a great mobile crisis course. We did a lot on different mental health diagnoses, studies, suicide prevention, become familiar with Columbia risk scale, all that stuff that, typically in the 911 EMS system, those are not really things that we go into in depth. Aside from that, we have to figure out what equipment CARES unit should be carrying. Typically in a 911 ambulance in the city of Madison, you have two paramedics that take turns doing patient care. So they have at least two bags as well as a monitor and other equipment. So we have to be able to pare all that equipment down and have it in a single bag that one paramedic can carry. So we are able to, when we identify somebody with acute medical needs, we can initiate treatment while an ambulance responds. So in the city of Madison, that typically is 10 minutes or less. So we're able to stabilize that patient. So we have, some trauma equipment, we have some airway type stuff. And so the goal is to, early in the encounter, if there is an underlying medical condition, our paramedics have to be able to rule that out early on and take appropriate action. And that's one of the reasons we tend to hire paramedics that are a little bit more tenured, that are able to have that eyes-on assessment. So some of our most typically used tools really are our assessment skills, basic vital sign gathering equipment, a glucometer, and we also have a breathalyzer. CARES is very innovative in that we're actually able to take patients to detox as opposed to other cities where that is strictly a police function. When CARES takes somebody to detox, that patient typically is in recovery and they had a slip and they're seeking that help out. So it's a very it saves police resources and it makes for a better handoff when we arrive at a detox facility. And much as with the paramedic equipment, when it comes to our vehicles, we're not in a large box ambulance. We have a fire department SUV. And initially, we kind of imagined we would be utilizing all these items such as clothing, and we had various types of food, and we had a cooler with several different types of drinks. One of the things initially we thought we'd be doing a lot was harm reduction education, and so we had a pretty wide array of harm reduction items. And over time, we have been able to pare down a lot of these items to things that we use more frequently. We also have some discretionary funds, so we're able to meet the needs of the specific patient that we're working with on a case-by-case basis. Sometimes buying somebody a warm meal or a pair of shoes is enough to keep a crisis from snowballing into something larger. Any questions so far? Any thoughts? All right, I'll keep going. Once we went live in September of 2001, one of our biggest challenges was in establishing CARES as another provider in the 911 landscape. So oftentimes we would arrive in an ER with a patient and we were met with a little bit of almost like suspicion, like, why did you bring this patient here? Like, what was the goal? And so we had to really work hard and do a lot of outreach and education with our ER partners to kind of reinforce this notion that when we do arrive with a patient in the ER, that patient was going to get to that hospital either via police or via EMS. But the bottom line is that that patient needed to be there. On the backside of that, we're actually very, very effective in diverting folks from using the ER. So when it's appropriate, we can develop safety plans tailored to that patient so they can remain at home or with a loved one. We're also able to take patients directly to psychiatric facilities. We don't have a lot of options in the Madison area, but we do have Dane County Care Center, and we also have Miramont in Middleton. Like I said earlier, we're able to take people to detox. So we have just a number of options because we're not in 911 ambulance, we have that flexibility. So it probably took about 2 years of us being in service as well as doing outreach with hospitals. But like I said, we have a diversion rate of about 15 to 20 patients. We bring one to the ER, and we have a lot of data capture, but we haven't been able to quite streamline how to pull those numbers exactly. But that is, that is 15 to 20 patients that would have ended up in the ER in the absence of cares. Any questions so far?
Paco, I'll just hop in real quick, just to clarify one thing. I know it might be confusing to folks, but an ambulance, by state statute, a 911 ambulance can only transport to ERs, and so that's when when Paco was saying they could have come by ambulance. That's true. The problem is that so many times when our ambulances pick up people, those people don't really need to go to an emergency room, but that's the only place we can statutorily take them. So having this option of cares to be able to transport wherever that person's feels safe, wherever that person's support network is really huge for people, because a lot of times we take them to the ER does a medical assessment and releases them, and they're downtown with nothing again. So I just wanted to clarify, but thank you for saying that, Paco.
I'm just going to share a question that came through chat as well, which I think I know Paco and Shay could both probably give some interesting comments towards. The question is about people who don't want to go voluntarily to treatment or to the emergency department, but maybe experiencing mental health challenges or crisis. I don't know, maybe Paco, do you want to say what that looks like?
Sure. So for the CARES program, our services are entirely dependent on the patient being amenable to seeking care and treatment. When there's a situation where there's a level of danger that calls for escalating the services involved in that particular encounter, we hand that off to the crisis unit from Journey and or MPD. They typically collaborate when there's an emergency detention situation occurring, and they will coordinate from there. What we can do is provide a better picture, especially if we got eyes on the situation. The crisis worker will document very in detail what things are transpiring that call for a higher level of care. But by design, the CARES team is not involved in emergency detention situations. And Chief Stedman can also elaborate on that further.
Yeah, I'll just simply say that really is the tenet of the team, right? We don't force anybody to do anything, and there's their Chapter 51 is there for a reason, and in the state of Wisconsin, only law enforcement can provide those protective services orders.
Yeah, I'll just say really briefly, I mean, this is a really important question because, so I came from the San Francisco Bay Area, the laws are different in California, and that is actually a big role that the teams play, is they have a much higher level of intervention in emergency detention. And so it's a real question, I think, for these type of programs overall. So I think Madison's approach is really interesting, and I think probably, has the greatest likelihood of engaging people if they're not fearful that the person they're talking to can detain them. So I think there's a lot of interesting, but there's a lot of depth to this conversation, I think. So I saw one other question came in about changes in trends of CARES calls over time, since both of you have been involved since the beginning, and I guess, I don't know, Diane, if you want to clarify a little bit more about that could also help local services figure out how to engage in prevention efforts, I think. So feel free to come off mute if I'm not capturing.
Yeah, I guess I just wanted to, the second part of the question is about, you know, if you're seeing these crises, if you're able to help other community agencies figure out what can we strengthen upstream to reduce the number of future crises? Like what are the unmet needs that people are really struggling with? And thank you so much for this presentation.
Yeah, you got it. Paco, I'm sure we'll have something to add to this, but I think, and I'll just kind of go back to the beginning with this. As far as the call types that we go on, it has changed a little bit, but not a ton. And the reason is because we looked at what other programs were doing for the types of calls that they were responding to, and they had already been through the rigmarole of figuring out what's best practice and what should we be doing. And the one thing that surprised us, though, was that most of the programs we looked at were going on at least 20 to 25% check welfare calls. So a check welfare could be anything from, you know, a person calling 911 and saying, hey, I haven't been able to get a hold of my grandma in 3 weeks. I live in a different state. Can you send somebody to check on her? To, you know, a citizen driving by somebody laying down in a park. Any number of things can be check welfare. And typically, unless there was an actual medical complaint that was being made, police would get sent to those check welfares. And what we found when we started taking the check welfare calls was that about 50% of them ended up having some sort of mental health component to them. So it was more appropriate for CARES to go on those calls, and it helped alleviate some operational stress from the police department as well. And that's part of our mission, right? Is to help law enforcement be available for the calls that they need to be going on, and we can pick up the other things that maybe aren't in a law enforcement sphere or shouldn't be. So we did start going on more check welfares. The other thing was the safety stuff. We initially, you know, had pretty strict safety mechanisms put in place so that our CARES team wasn't going to a person that had a weapon that they were waving around in a dangerous way. So anytime that the 911 call taker recognized it was a behavioral health emergency, they would ask safety questions. Does the person have a weapon? Are they acting violently? And if the answer is no to those questions, then CARES dispatches directly to the call without any other help. But if there is a domestic dispute where somebody's being violent, somebody has a weapon that they're brandishing, we will send law enforcement first and do a co-response. But what we found is that a lot of homeless people carry pocket knives. And so if a homeless person has a pocket knife, should we send cops first? We decided that it's intent of the person, and that, you know, CARES can go on a call with a homeless person that maybe has a weapon, but they're not acting violently and they don't have the weapon out. And so we've adjusted a little bit, but our call types in general haven't changed a whole lot. But we do meet with a lot of our community partners to talk about this stuff and to say, hey, you know, if you need us for this, you can call us. We ran into a problem that the hospitals were actually calling us because they were having behavioral health emergencies inside the hospital. And we actually had to stop that response because, you know, the person is already in a facility that is supposed to be able to manage that. And the CARES was developed as a 911 response to community nonviolent behavioral health responses. So we had to tell the hospitals, hey, this is an appropriate use of CARES. You already have medical professionals there and behavioral health professionals, but they were calling us for a little bit. So some of those little tweaks have happened. And Paco, I don't know if you have anything else to add into that.
Yeah, like Chief Stedman was saying, there were situations where just because there was a mention of a knife being present, they would divert that call from CARES and make it a police-only response. And like Chief Stedman was saying, you know, virtually every unhoused person walking the streets of Madison has some kind of means to protect themselves. One of the things that has changed too over time is, and I'll say one of the greatest tools that this team has is that we have the ability to look at a call, look at call notes on our dispatch system, and we can oftentimes get a name, and we have some familiarity with a lot of high needs patients in the community. And sometimes the statements being made to 911 are such that they will send, you know, half a dozen cops, a fire truck, an ambulance, based on what a person is telling the call taker at 911. But because we're familiar with that particular individual and we know that this is not too far of their baseline, we can actually get on the radio and cancel all these services and put them back in service so they're available for other things, and we can go serve that person's needs based on our familiarity with them. So that has been really helpful. It's kind of hard to, somebody made a question about cost saving analyses. That's one area where we make a big impact. It would be very challenging to ascertain exactly how much in monetary figures, but it is significant. The other part of the question was helping local services. We're often able to collaborate, and I'll give an example here. For many years, the men's homeless shelter had a policy where if one of their guests had presented with suicidal ideation, the only disposition for that is that they would have to go to the ER via ambulance to be assessed. And then if they were subsequently discharged from the ER, they would have to come back to the shelter and show their paperwork that they were safe to be there, which is incredibly expensive, and wasteful, and does not provide for really appropriate care for these patients. So we were able to work with the management and staff at the homeless shelter to modify that policy a little bit so that guests presenting with suicidal ideation could be assessed either by CARES, or they could call a crisis line, speak with a crisis worker, and put a safety plan in place, and allow that patient to stay at the shelter, not have to go out, because oftentimes they would be discharged at midnight, 1, 2 in the morning, and sometimes not have the means to get back to the shelter. Now they're in the street, and that could also cause other calls for 911 services. So that's just one example. We have been able to collaborate with other services to provide better care.
Maybe we want to take a few other sort of implementation questions that I saw populating the chat here around training and hiring. And yeah, I think, and sort of proactively trying to spread the word about CARES and what that has looked like. So I don't know, Trey, you want to take the hiring one?
Yeah, absolutely. So, there wasn't anything in state statutes from DHS or anything else that kind of guided us as the fire department as to what sort of training a paramedic should have to work with a crisis professional in a co-responder model like this. DHS 34 outlines what mobile crisis response should look like in the state. I kind of already mentioned that, but it only talks about the requirements for the crisis worker. It doesn't say anything about the EMT or the paramedic or the law enforcement officer or anybody else that's co-responding. So again, what we did was, we reached out to NAMI. So all of our folks have taken the 40-hour CIT course. But in the atmosphere of what they're doing, our paramedics do rely a lot on the crisis worker who already has the training. But there's definitely a need for that paramedic to have some good understanding of how to deal with these situations. Now, the interesting thing might be, well, you're like, hey, these are paramedics. Shouldn't they already know how to deal with this stuff? Well, sure. But in the paramedic curriculum, it's 1,200 hours of didactic training. 16 of it is based on mental health. And that's probably similar for police academies and everything else. So it's certainly not enough training. We get some de-escalation training and some little tidbits here and there, but it's really all about, stabilizing a person and getting them to a hospital. And so the focus was never on sitting down with people for 2 hours to truly listen to them and figure out a plan. And again, the crisis workers, that's their job, but the paramedics need to be able to back them up with everything that they're doing and come to an agreement. Because, right, if you have two providers and one says, hey, this person needs to go to an ER for a medical issue, and the other provider says, well, this person needs to go to this, this psych, but needs to go to Miramont and Middleton, who wins that conversation? And so we had to do a lot of, these are two different agencies with two different sets of supervisors dictating what happens on a call. So there's a lot of collaboration that needs to happen. So is just to get back to the training. It was kind of us to make it up. DHS, the state, the county, nobody had told us what we had to do. But we're trying to provide a framework moving forward to what would be a best practice in the state of Wisconsin, because this is the CARES is the first mobile crisis response team run out of a fire department in the state of Wisconsin. So, you know, there was a lot of things that we didn't know, and that we kind of had to just ask questions about. And Paco, I don't know if you have anything else. I mean, we got lucky. Sorry, I'm going to say one more thing. We got really, in my opinion, lucky with our hiring. You know, Paco came along at the right time. Mark Norton, his partner that we hired in the very beginning, came along at the right time. Paco's bilingual, has a, you know, a more in-depth mental health background than almost any other paramedic that we've seen. And so, and the other paramedics we've hired since are all, like Paco said, seasoned. They've spent a lot of time in the field, but the questions we asked them about were around, right, compassion, caring, your ability to you know, deal with adversity in a different kind of way, and work with a crisis worker, something that nobody had ever done in the fire service. So it was challenging, but it in my opinion, everything has gone pretty well. And of course I'm biased because, you know, but Paco, please add in anything that and you know, I think it's important to say, what did we miss? You know, what should we have done? Is there anything that we could have done better?
Yeah, I think another big part of that is having leadership that has your back, you know, no matter what. And in this work, there's a lot of gray areas. And I always say my North Star is always doing the right thing for the patient and then asking for permission later, so to speak. So I think just being able to, in order to have these novel approaches, you know, sometimes we had to do things like, you know, we had a patient who was very ill with schizophrenic symptoms, and he thought his parents were trying to murder his dogs. And in order for him to accept care, he wanted to make sure the dogs were safe, and we achieved that. He requested that we transport the dogs to his grandmother's before taking him to the hospital, and so we did. And it's not something that I've never heard something like that happening before, but we did it, and then, you know, subsequently called Chief Stedman just to make sure, you know, we're on the clear with that. But there's, you know, many situations like that. Sometimes transporting somebody outside of city limits is the thing that needs to occur, you know, to prevent things from snowballing. So, and that kind of goes along with a question about what 2 or 3 things that we think we can do to be most impactful to prevent crises. And I think early intervention is absolutely the key here to prevent things from snowballing. I think we're collectively in the society, in this place and time, we're doing a better job normalizing mental health and talking about it. And I think there's many more resources out there even than just a few years ago. So having, you know, warm lines, crisis lines, 988. I'm partial to NAMI. I volunteer with them. They have a lot of amazing peer support led programs. So there's definitely a lot more out there to provide a better impact in crisis.
I will, I just want to add one thing, and then I'm going to bring up a couple other questions. And just in terms of what Paco just described, like transporting somebody's dogs before bringing them to the hospital, I can think about many situations as an inpatient psychiatric nurse where if that problem could have been solved before the person was hospitalized, they would have had a totally different experience of mental health treatment once they got there, right? I mean, it's like trying to deal with somebody's like human problems, like that they pets, family, whatever, before getting to treatment. It changes the whole experience for them. So it's so meaningful in so many steps of the process. So I just wanted to highlight that. And then Tim asked about the link with Journey and their ability to access the treatment record and what role that has played in making this process work. So I don't know, either one of you maybe.
Yeah, I mean, I'll just talk about initially, you know, there was a lot of HIPAA business agreements that had to be signed, right, between different agencies. And so luckily we worked through that pretty pretty well with the city attorneys and everybody else. And so yeah, once the HIPAA agreements were signed, it's of great value for the journey crisis worker to be able to open up their laptop and bring up the person's name, birth date, type it in, and see their treatment plan. I think it's still true. This was a data from a few years ago, but about 60% of the people that we see are in Journey's record. And so that's incredible, right? Like on the way to the call, the Journey crisis worker is in the passenger seat on their laptop looking up a person. And certainly when you walk into a behavioral health crisis and you know the treatment plan that's already in place and you know what the person has already received, and that's a great benefit. So having Journey there and having the ability to share information like that is really important. And the paramedics can do the same on their side. Each employee does a chart in a different system. So the paramedics have Image Trend, Journey Mental Health has their own software. And so when we bring data together, it's hard, right? You're bringing from two totally different software suites to bring in data together to figure out, what everything from patient demographics to the outcome and everything else. But then there's also the 911 data. So we've got data sets from 3 different agencies coming into one central warehouse where we have to, and so we had to hire a data analyst. I wasn't able to put together a data dashboard in Power BI and evaluate all this data. It wasn't something that I had ever been trained for. So luckily, and it brings to the point of what Paco said earlier, is that you need a lot of support around teams like this. You can't just throw people on the streets. You need good clinical supervision. You need data analysts, and you just need the support around them in order for them to succeed.
I'm trying to think, maybe we'll do just a little bit on the research at this point and then come back to some more questions. I think, this is extremely rich conversation, but, just to sort of tie it together with the research, and then we can take questions in any of the content. So I'll just talk a little bit about, the connection to and sort of the conversation for the series is around recruitment and how to link. So an innovative program like this, like what Madison has built in CARES, to research and how do we make that meaningful? So, I can just say my angle was really on the implementation here, and I wanted to take one specific approach, which was about who is doing the job and who is in places, like Madison, where the, programs are getting set up for the first time. What is the workforce experience like? How do we scale, a program like this in places where they don't have an existing infrastructure, to like get started with? And so I came from the San Francisco Bay Area and was able to, as Che mentioned, they had a team that had been around for a few years called Street Crisis Response Team. And so I interviewed a handful of their team, and then thanks to the support of Chief Stedman, was able to recruit members of the CARES team to have a richer data set looking at 2 different programs and different types of implementation. So I got to meet Paco, and this is just the overall description. You can go to the next slide. So I did the qualitative approach. I think I started from a point of view that, this is a new workforce, and, it's people who have a background in being paramedics or being crisis responders or being social workers, but now are sort of transitioning into a new role. And so for that reason, I felt like getting some qualitative data to understand their experiences would be valuable and would actually help understand how a new city or other places who are trying to build their programs could make it work. Next slide. So these are the folks who I talked to. A lot of behavioral health clinicians. That's a lot of the people in San Francisco met that classification. A fair number of paramedics or EMTs, and then the other types of providers are listed. I can go to the next one. So pretty good range of demographics and a diverse group of workers here. And so I think it was really interesting to see how different parts of social identity, factored into, some of this conversation and how people approach their role. So yeah, pretty even split in gender and range of ages. Next one. So qualitative analysis, it's not totally finished, but we're really trying to pull everything together at this point. So, there's a lot of people's prior work experiences that they bring into their role in crisis response. And so I think the strengths, and I think, Paco has taught me a lot about sort of how this worked for him, and I think has been really helpful to understand the value of, having a background that allows you to build rapport with people, and sort of in different, so people who come from different professional backgrounds may have that skill to a greater or lesser extent. And so being able to leverage that for these teams, I think has been really interesting to see, and how, certain people, I think, and I saw in San Francisco, people arrive at this job not exactly knowing what it is because it's new and they don't have like a bunch of colleagues who've already done it. And some people are like, I'm in the wrong place. This is not for me. I don't want to be in this sort of, as Paco said, gray areas of figuring things out. And then, having to, figure out a way to make it square with the paperwork later. Some people, I think, thrive in that environment and some people do not. So that was sort of an interesting finding. And you can go to the next one. Yeah, people arriving into a job where there may not be really defined rules, and they may be trying to, to sort of figure things out on the fly. So some of what I focused on, and my background, as I think Barb said in my introduction, I researched workplace violence towards healthcare providers in the hospital setting. And I really wanted to understand safety experiences and how this was different than being in the hospital. And so there's a lot of differences between the San Francisco approach, as I mentioned when we were talking about emergency detention. Those folks were much more closely involved in initiating involuntary holds for people who needed to be chaptered. And so that, I think, put them in a much more vulnerable position a lot of times. So those clinicians especially sometimes felt like it was not a very safe environment. It was not a well-controlled environment because they were being asked to do things they weren't comfortable with. So anyway, I think there's a lot of factors that in the way that different programs have rolled out that have sort of contributed to these different types of experiences. So you can maybe just go to the next one and I'll stop there. So I think, the big takeaway is just that, and this relates to the data questions that came up in the chat. You have a new program like this, and it's doing a lot of things that are meaningful and are clearly the right thing. We should be having people with better mental health training, being the first responders in communities. How do you capture that, and how do you describe it in a systematic way that can inform policy decisions, and how do you build support for a program like this in the long term, so it's not just a sort of like flash in the political pan where you have the right people in charge and it can sort of be undone if there's not enough documentation of the good that it's doing. So I think those are the questions that motivate me in terms of understanding programs like this one, trying to improve mental health care delivery. And I think I'll just stop there in summarizing the research component, and we'll come back to any questions that people have about the program or about research in this area, and we can keep discussing them.
There was a question from Dan about peer support that I'd like to just address real fast. So Dan, you're right on with integrating peer support. That is something that we definitely identified as a best practice. San Francisco's team has peer support. We Honestly, it came down to budget issues, hiring a third person to ride on the CARES teams. Excuse me. And also, you know, when you think about peer support, people have very specific lived experiences that can help with other folks that are dealing with something similar. So what we find to be budgetarily better, but also maybe even a better practice, is to refer people to peer support when needed. Right. Paco mentioned that he has, you know, we have access to peer support here in Madison. And so if we really think, if the team finds that a certain type of, whether it's peer support for addiction or whatever it is, they can connect that person after the fact. So we use peer support as a resource, but they're not on our team. Certainly, it would be great to have a cadre of peer support folks that were ready to respond with us, but it's just not realistic, unfortunately, in our system.
Yeah, I would also expand, you know, every mobile crisis team across the country is a little bit different. For us in CARES, we are often responding to calls that are a little bit more acute, where there's an element of risk that's a little bit higher. And sometimes having, you know, 3 responders on scene could complicate things further. In my perspective, it would be amazing in the future to have the budget to have maybe a peer support, like a generalist peer support person on staff that could do follow-ups, you know, a day or 2 after a call. But as it is, you know, with the CARES team, I think it's a very dialed in model, and it allows us to go to calls that might be a little bit higher acuity that we would otherwise not be able to respond to.
So I have a really quick thinking question around, I don't know if it's a quick question, on thinking about recruitment science and building the relationship between a researcher and a community partner, which is what the CARES team is. So do you have some thoughts about strategies that you thought was effective, that either Rachel, you used, or Paco and Che, you thought about, to forming what this relationship look like to move forward the work of CARES?
Well, I can say, you know, as from the researcher perspective, you know, I had gotten pretty plugged into the team in San Francisco before I moved here, and actually, you know, had met their medical director, and sort of had some shared interests in really digging into what you could measure about how well these teams are working. And I think, I mean, the big advantage here is that, you know, and yeah, Jay can correct me. I mean, these programs are new. Like, there's a real need to understand what's happening from a research perspective, like from a policy perspective, right? There's all these questions. And so it's a good moment for a researcher to sort of enter into the conversation, because there's meaningful questions to answer in the real world, you know, so you don't have to do a lot of convincing about the topic. I don't know, I think maybe that is sort of how I would say when, you know, when Shay and I first met and we were having a conversation about alignment with research, and it's like, yeah, I mean, everybody's trying to answer this stuff, you know, so it wasn't like I was trying to sell a topic that felt different. So maybe, I don't know. I'm not going to speak for Jay, so I'll
No, I mean, honestly, there's just not a lot of research out there, like large research studies. There's not a lot. Like when you Google this stuff, you don't find a bunch of really, you know, long-term longitudinal studies that have produced anything. And so I think the one thing that kind of has helped us a lot, and it's not necessarily research, but it's getting there, is Dane County Human Services and the City of Madison received a technical assistance grant from the Harvard Kennedy Government Performance Lab. And so they were basically just reaching out, right? It's non-monetary, it's just technical assistance. So we meet with them once a month, along with like 10 other cohort cities from around the country that are running similar programs. And again, document sharing and sharing best practices and doing all of those things were probably what helped us the most. And then from that, they're talking about where do we go for research. We actually hired the Harvard Government Performance Lab to do a 1-year study on CARES. We had some extra money from ARPA funds, and so we essentially gave them $150,000 to research CARES over this next coming year. There's just not a lot out there, and I don't speak very well in this world because I'm not a big research person, but that's kind of like the way I feel. There's just not a lot out there already, and so this is all great.
Well, we are 3 minutes to our time, and I just want to take this opportunity to say thank you, Paco and Jay and Rachel, for this really wonderful presentation, just informing us on what this team is doing and how this is impacting mental health outcomes. I can see lots of connections, not only with Rachel, but there was comments in the chat about, hey, have you thought about connecting with other people that can help with some of your data analysis? So, so it seems to generate some great excitement for people that are on here. So the people that are still here, please, 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 we really would love your feedback on our series. So click that link and complete our surveys. And I just want to remind everyone, we have a upcoming DRISS presentation again on December 13th. So in 2 minutes, any other closing thoughts, Rachel, Paco, or Jay?
I wanted to answer a question from Anne regarding to whom we provide proactive education. Unfortunately, we're not in a position to necessarily go out and provide education necessarily. We do try to do a lot of outreach to different groups, like school groups, officers, mental health entities, and it's more about how to better utilize care services when they do have a need for a response. And so I do try and do that within the confines of my schedule as much as possible. I dropped my email on the messages if anybody would like to connect further.
Thanks for the opportunity to join today and everybody's engagement and questions. This has been great.
Thank you. We appreciate this presentation, and I'm going to close this out.